Good evening, everybody. Thank you for your patience. David Johnson's my name, and after all that little bit of kerfuffle, we are actually only running 3 minutes behind schedule. So I'm pretty excited about that. But yeah, I'm sorry about that. We did have a data projector, and of course it blew a bulb about half an hour ago. So I've just done some quick handiwork and salvaged one off the roof. So big thanks to Luke Armstrong at the back. Volume, you can't hear me? Where's my IT man? This may be very loud. Hang on a second. Testing 1, 2, 3. Better? Okay. All right. A very big welcome to you all, and thank you so much for coming out to to the Functional Movement Training Centre and St Andrews Hospital. This is my office. This is my second home, and it's a pleasure to have you here. And of course, it's a great pleasure to have Dr. Aseem Malhotra and Miss Christine Cronau here this evening to participate in what I put down there as a intimate Q&A. Now, we only really published this at the beginning of this week, and I thought there was only going to be a handful of people, and it was going to be very intimate. But obviously, Dr. Malhotra has got a bit more of a following than I anticipated, and we've filled the room. So it may not be too intimate, but I definitely want this evening to be very casual, and I don't want anybody to feel like they can't ask a question, no matter how silly you may think it is. And I know that Christine and Aseem have really travelled around Australia, Aseem around the world, answering questions about health, and so it's a really unique opportunity to have these people here. And I just asked Aseem on a whim through Christine, who I know well, would Aseem be interested in giving a little seminar to our community, the community that I work with closely, and the vast majority of my patients, and I was really surprised. I didn't expect Aseem to say yes at all. You know, he's a busy man, and he's on a whirlwind tour around Australia, and here he is tonight. So Aseem, thank you so much. We really appreciate it, and I'm really looking forward. Been excited to have this event tonight all week. So I just want to talk to you a little bit about what we do here, and this is what we call the Functional Movement Training Centre. It's an integral part of my practice, and I talked to a cardiologist on Monday, and I said, Dr. Mai, is Dr. Mai here, by the way? He didn't come. All right. He's a cardiologist, and I said, please come along, Ngi. I went to uni with Ngi. We graduated together, and he's a cardiologist now, and I'm a neurosurgeon, and I said, I'm hosting Dr. Malhotra. You've heard of him, haven't you? And he said no, so I had to send him a couple of links. I said, yeah, this guy's the most famous cardiologist on the planet. And he goes, oh. And I sent him a couple of YouTube links, and he said, oh, this guy seems to know what he's talking about, and he said he'll try to come along. And then he said, why, by the way, you're a neurosurgeon, what the heck are you doing hosting a cardiologist at your neurosurgery centre? And I said, well, yeah, remember, before I became a neurosurgeon, I was a doctor, okay? And it is every doctor's responsibility to focus on the fundamental pillars of health. And that's what we do here at the Functional Movement Training Centre. 2 pillars of health that we focus on very heavily are movement proficiency, distinct from exercise, okay? Exercise can be very dangerous for you. Exercise does not necessarily help the health of your spine, but functional movement proficiency is always very good for you, and it is an essential fundamental pillar of health. When our patients move well, does that mean they are getting stronger, fitter and faster? Absolutely. But if we try to make people stronger, fitter and faster without first focusing on movement proficiency, then they will get injured. Okay, so we're not allowed to use the word gym here. This is not a gym. Okay, anyone who uses the word gym is going to get the boot. Aseem, what is this place? Christine, what is this place? You got it. We can't chuck Aseem outside. All right, so that's my little shameless plug about what I do here and why, as a neurosurgeon, I'm hosting a cardiologist who I refer to as the Jordan Peterson of lipidology. Okay, have you guys heard of Jordan Peterson?
Yep.
Only about 50 billion views on YouTube and subscribers. So as far as lipidology is concerned, Aseem is all over it, and we're going to learn heaps tonight. So, who is Dr. Malhotra? Now, Aseem, it's a pretty short list here. I know that you could go on with about 20 slides, but obviously is a practicing cardiologist, interventional cardiologist. That means he's doing angiograms, he's shooting dye up people's coronaries. He's probably inserting stents, or you used to insert stents regularly, I would imagine, in your early days. He's a researcher, he's an author, and I would all encourage you to look up the Piopi Diet book. Is that the full title of the book, Aseem? What's that? Piopi Diet? Yeah. And obviously a health campaigner. I put in there Crusader, okay? You like Crusader? Because it's a real crusade, and it's really tough sometimes, and in my own experience in campaigning and being a bit of an activist in trying to educate people, sometimes you're doing the best you can and you just get knocked down all the time, and you have to be a bit of a crusader, and you have to have a bit of a tough skin, and some weeks are really tough, and you go, well, why am I doing this? Why don't I just stick to doing neurosurgery and stop actually trying to make people healthy? Because it would be so much easier. Is a big public figure, an influencer, a media activist. You know, BBC, Fox, CNN. He's done it all, and all in the name of trying to improve global health and enlighten people, and make health simple and easy to understand. So I've just got a few quick slides because I'm not going to take up the time, but it's really just to whet your appetite and to prime you guys for the Q&A later, because that is the best part of tonight, is going to be listening to you people ask questions and you know, untangle a few of the misconceptions that you may have about health. Okay, so I graduated medicine 1996. And you know, I was excited because I was going to help heaps and heaps of people. Okay, really, as a profession, we're doing a terrible job. We really are. It's almost embarrassing, and I have no hesitation in saying to my patients that we are failing as a profession. We are very good at helping about 10% of the population. Okay, we're very good at helping 10% of the population. You know, if you come into hospital after being hit by a bus, if you come into hospital after contracting pneumonia or getting food poisoning or suffering the influenza, we're going to do a fantastic job at helping you. But the other 90% of people, we are neglecting. So the current conventional medical practice is a little bit like we're fantastic lifesavers at the beach, but we are terrible swim coaches. We're not teaching people to swim. We're rescuing them as they're drowning. Okay? And that equates to 90% of fatalities. And that means that 90% of people are dying with chronic illness. And we no longer have this attitude that we can die healthy. And that is a real misconception. We should be able to die healthy. We should be able to grow old, playing golf, lawn bowls, enjoying a cup of tea with our friends and family, and then one day we contract pneumonia and then we die a couple of weeks later. That's how we should die. But now our hospitals are filled with people suffering chronic disease, our nursing homes, chronic disease, and then after many, many months or years of suffering chronic disease, we then die. and that is an unsatisfactory report card. And here's some evidence, right? Here's some evidence. These are concerning stats, and this just came out recently, that we're getting worse. Our obesity rates, our chronic disease rates are not improving with all of the medical science and all of the medical technology. Obesity approaching 50% of the population, billions of dollars being spent on obesity. Our children becoming obese. I think the stats are 1 in 4. 1 in 4 children now are overweight or obese. Now those guys are doomed. If you're obese as a child, you're probably never going to lose that obesity. Okay. And the budget just came out. Where's our gentleman? Just to pipe up with what you saw in the newspaper, just very quickly.
Yeah, very simple. It's $12 billion is the price of obesity. The equivalent of 2/3 of Queensland's health budget is being spent on the state's obesity crisis, a diabetes expert has revealed.
Thank you for that. Yeah. So look, it's non-conjectural. It is it's not even open to debate. We are doing really badly. So let's have a look. Where have we gone wrong? Okay. Is it hard to be healthy? Like a baby's born and it just comes out of mum's tum, and what does it do? It just knows what to do. It cries and then it wants to feed. Okay, it knows how to be healthy. It didn't have to go to uni or go to Google to work out what it needs to do to be healthy. So being healthy should not be complicated. All right. First little message. Your body will be healthy if we just eliminate barriers that obstruct that health. Okay, so we don't really have to do anything. Our bodies are programmed to be healthy. We move well, we eat well, we sleep well, and we keep stress under control, and we will just be healthy. The only reason we are not healthy is if we start propping up barriers to being healthy. Okay? So if you think about it like that, just don't put the barriers that are in the way of your body just doing its thing. You don't have to do anything. Okay? So later on we'll talk about ketones, and we'll talk about nutritional ketosis, and we'll talk about LCHF. These are just ways, they're not really making your body healthy. What you've done is you've eliminated the things that are barriers, and your body's just doing its thing. Okay? So think about it like that. It makes it so much simpler. So we have to make the correct choices, right? We have to make the correct choices. And the correct choices can only be made if we are informed, okay? So how many people know that their whole grain is 70% glucose? Not many people. And almost every single patient that I see that has the elements of the metabolic syndrome, I always ask them, what did you have for breakfast? And almost all of them will say some form of grain or cereal. And yet they don't know that an oat is 70% sugar, okay? And when they go and see their doctors, the doctors are just as sick as they are. Okay? So we've done research on that, and our general practitioners and our clinicians are just as sick as their patients. So, you know, I don't think that our doctors are informed and are able to deliver the right messages that give you the ability to make the right choices. Industry and commercial misconduct at the highest level. Okay? This is from the Diabetes Foundation earlier. I think it was this year or late last year. And that's their recommendation to a diabetic. So I don't know whether it's just complete insanity or whether there's some sort of vested interest built in there, but when you look at the conflicts of interest of commercial food industry with our pillars of education, there's a really big concern here. Okay, so I think we really have to think, we have to act at a community-based level, and we have to educate each other to start to make some real changes. So our pillars of health are no longer reliable sources of guidance, like the food pyramid's corrupted, sponsorships and funding and conflicts of interest, hospital food. I've been lobbying for a long time to change hospital food menu selections, okay, so that the patients don't just have to wake up and have their Wheat Bix and cornflakes in the morning and orange juice and bread with jam. and I've started to put low carb on the medication form, because you know the medication form where you write the medications that the patients are on. I've started to write, you could write Panadol and Nurofen or whatever if they've just had surgery, okay? But I'll also write low carb healthy fat. And the nurses are going, what's going on here? This is not a tablet. But you know what? It's more powerful than a tablet. Okay, so the nurses are now starting to write it in the chart too, but they're getting it a bit wrong. They're calling it low fat, high carb, Christine. They've got this, LFHC, which is a bit of a problem. But anyway, you get my drift. So the other last thing before we get Aseem on is that our politicians are not in charge. Okay, we may think that our politicians are in charge, but they're not. They are our elected. We elect them, but we are their boss. Okay, so and trust me, I know this. My brother used to be a politician, and he's terrified of what his constituents think of him. So if you let your politicians in your electorate, in your constituency, know that you're not happy, they will act. They will act. And if there's enough of us that are creating this movement and this groundswell from the grassroots level, then we will be able to influence what our politicians are saying. And Aseem's done it at an incredible level. I said Aseem's a parliamentarian. He's not really parliamentarian, but Aseem's spoken at the European Parliament and in the British Parliament, and I think you've got a few patients who are politicians, haven't they? So he's got a real leg up in that way. And the last slide, remember that this thing is addictive. Okay, glucose, starch, the same thing. It's addictive. So once you get that addiction, you need a little bit of guidance. You need a little bit of help to get off that addiction. Just like an alcoholic, just like any illicit drug use, it can be exceedingly difficult to remove that addiction. I haven't even won with my own mum yet. She can't help herself. She's got to have her Wheat Bix and cereals in the morning too. So it is tough. And the solution is simple, as you'll find out later tonight. And I just wanted to, last slide, on Sunday I met Christine Graham, and we just had a chat at your conference on Sunday, and there he is, and he showed me a photo of himself, and I took that photo in the conference, and I was just he was sitting next to me, and I was so chuffed to see someone just repairing their own metabolic syndrome just with education, just with knowledge. Knowledge is power. So without further ado, I think we can safely switch computers. Aseem, come on out and do your stuff.
Lovely. Right, thank you, David. I'm really delighted to be here. Just finishing, we've done 6, myself and Christine have been speaking in various cities in Australia over the last few weeks, so we've done 6 cities, which is great, and I do love your country. I'm trying to work a way to come and work here for a few months. Ideally, I live in London, so I want to come during the winter time in London. The summer here is perfectly great. I think
make sure you come to Brisbane.
I think David's spot on actually with what he said around the fact that we do some amazing things in healthcare, really, really amazing things, and myself and most doctors, I'm sure, are very proud to be privileged to do what we can do for our patients. But this is mainly now in acute care where we get the best value, and unfortunately the situation has become really dire where we are not really helping most of the population with the way we manage these chronic diseases. So over the next half an hour or so, I'm going to try and give you my insight into why we have this healthcare crisis, specifically talking about how saturated fat cholesterol and the overprescription of statins has been a big contributor to that. Can I just ask, can you raise your hand, how many doctors in the audience today? Okay, that's good, there's a few, there's a handful, excellent, very good. So, before I start, who thinks that the intake of dietary saturated fat causes heart disease? Put your hand up. All right, 1, 2, okay, a few, good, all right, excellent. Who thinks that high cholesterol is a major risk factor for heart disease? Okay, a few more, excellent. And who thinks that statin medications have reduced death rates in the population for people with heart disease? Okay, a few, all right. Excellent, right, so a bit of background about myself. I'm a practicing cardiologist. I've got a number of different roles and different hats. I'm speaking in a personal capacity today, but I'm also a trustee of a prestigious independent health think tank called the King's Fund, which advises government on health policy. I've done a lot of work with the Medical Royal Colleges, which is the umbrella body that represents all doctors in the UK around obesity strategy, around overprescription of medications. And I was recently awarded a visiting professorship in evidence-based medicine in the Bahiana School of Medicine in Brazil. I did for most of my career, which is, I've been qualified now since 2001, most of my cardiology career was doing interventional cardiology, which is, as David described, really putting in stents and doing angiograms on patients. In the last few years I've shifted more towards prevention, and hopefully by the end of the talk you'll understand why that is. So let's start with something interesting, a case study. So this is a patient that came to see me a couple of years ago now. So for those of you who can't read at the back, I'll just repeat. Essentially, Tony Royal was a 55-year-old man who came to see me with a background of being an international airline pilot for about 15 years with Virgin Atlantic. He was very active. He was doing triathlons, but he admittedly didn't have the best diet. He didn't think it was the unhealthiest. He followed the conventional advice, low-fat, high-carbohydrate diet. But he was overweight. He had increased waist circumference of 38 inches. And he also had a high BMI at 28. Unfortunately, a few months after, before he saw me, he underwent a routine check, which he's supposed to do as an international pilot, just to check his risk of heart disease and heart attack, etc. And in September 2014, his total cholesterol came back at 6.4, which many of you here, and certainly the doctors amongst you, will think that is high cholesterol. Anything above 5 apparently is high. And his HDL was 1.2, the so-called good cholesterol. So his ratio, which is actually most important, which I'll describe in a second, of total cholesterol to HDL, which is what we use to calculate risk of heart disease in the next 10 years, amongst other things, was 5.3, which again is on the high side. It should ideally be less than 4, even better if it's less than 3. So we had a risk assessment done. His risk of a heart attack or stroke in the next 10 years was estimated to be just over 12%. In many places around the world, and I think even including Australia, it suggested that patients who have a risk of over 10% over the next 10 years of having a heart attack or stroke should be offered, or maybe in many cases coerced, into taking statin drugs. But I will talk about evidence behind why that is a very, very unethical and misguided approach shortly. Unfortunately, a few months after he'd had this routine check, so in December 2014, he suffered a heart attack. Luckily, it wasn't something that caused him serious disability, but ultimately, when he had an angiogram, one of his vessels was almost completely occluded. He had a stent put in, but there wasn't significant damage to the heart muscle, so he had what we call good left ventricular function. And then he was also put on what we normally do in routine practice for these sorts of patients is a cocktail of medication. So he was put on 2 blood thinners, he was put on a high-dose statin drug, he was put on a beta blocker. And the reason we prescribe high-dose statin drugs for all heart attack patients is a published evidence suggested that these patients benefit irrespective of their cholesterol, to the point where for most of my career, I remember we didn't even check cholesterol in hospital in patients who come in with heart attacks. We don't bother. There's no point. What's the reason? So we would just put them on high-dose statins and we would discharge them on the rest of the medications. About a year, just over a year later, after he's been discharged, he starts feeling actually very unwell. He reports that he's got lack of energy, lack of drive. He's got muddled speech. He's got memory disturbance, muscle aches, and erectile dysfunction. At this point, Tony Royal, who actually was no longer able to fly, so one of obviously the rules is international airline pilot with Virgin Atlantic, he was no longer able to fly after his heart attack. So he went back to doing what he was doing before he became a pilot, which is that he was a maths and physics teacher. So he's more informed than your average patient, and he's actually very good with statistics as well. So he starts looking at the literature and all the medications he's taking, because he's suspicious that these symptoms could be side effects of the drugs he's on. And when he looks through the literature, one, in terms of the absolute benefits of these medications, which I'll come on to, and realizing they're not actually that beneficial, or the benefit is very small, as well as looking at the side effects, he decides that he's going to stop taking 2 of his tablets, a beta blocker, which he thought maybe slowing it down a bit, but more importantly, he felt was the cause of his symptoms was the Lipitor, the atorvastatin, high-dose statin drug of 80 milligrams he was on. And within a very short space of time, having felt pretty rubbish for about 3 months, within weeks of stopping these medications, he's feeling almost back to normal. He's like, wow, complete marked improvement. His energy levels are back, his mental acuity is back. At the same time, around this time, he starts looking into the fact, well, he's still overweight, and he starts reading up information that he's getting through media reports and some of the literature in medical journal publications, a lot of stuff I've been involved with at that time, on low carbohydrate diets. So he decides to change his diet drastically, and he cuts out, and many of you who are low carb would know this, but for those that don't, he specifically cut out of his diet all sugar, cakes, biscuits, juice, starchy carbohydrates, and increases intake of non-starchy vegetables, oily fish, eggs, full-fat dairy, nuts, and mixed berries. And just from doing that, and his exercise levels have remained exactly the same, within 3 months, he's now lost 3 stone. His waist circumference has gone down from 38 inches to 30 inches, so quite a significant drop. And interestingly, if you see, I don't know if you can see at the back, but his cholesterol, actual total cholesterol went up here from, I think it was 6.4 before. It went up to 8, which would alarm many doctors, maybe most doctors. Wouldn't alarm me, but would alarm many other doctors. But more importantly, his cholesterol profile improved. So his total cholesterol to HDL ratio, which was previously 5.3, has come down to 4.4. It's not perfect, but it's dramatically better, despite the fact his total cholesterol's gone up. And then he comes to see me. And he comes to see me, and I'll never forget this, because he comes to see me in my private offices. Most of my cardiology work is in the National Health Service. 95% of patients is in the National Health Service, but I do occasionally see people privately. And he comes to see me privately, and he comes and he walks through the door, and he looks very fit and healthy, and he tells me his story. And at this point now, he's stopped all his medications. So this is a heart attack patient, he's had a stent, he's stopped all his medications, his aspirin, his statin, everything. He's changed his diet, and he's never felt better. So that was a little bit alarming to start with. And then he says, the reason I wanted to speak to you, doctor, he's read about me being a sort of more progressive cardiologist who's interested in this space, is I'm now thinking about doing Ironman. So just imagine that scenario for a second. A cardiac patient in his mid-50s, had a stent, he stopped all his meds, and now he wants to do Ironman. Anyway, I had a conversation with him about this. It's something he really wanted to do. He felt it was really important. I told him, well, from his heart perspective, he didn't need to do it. In fact, he may well be increasing his risk of having a fatal rhythm disturbance, although I couldn't quantify it from doing a high intensity exercise. But I said that you only need to do moderate activity from a cardiac perspective, but also I want you to think about your medications. Maybe you should go back on aspirin, and perhaps a lower dose of the statin drug. You're on a high dose. Often patients get side effects at higher doses, but don't get them at lower doses. So he said, okay, doc, I'll go away and think about it. And he called me back 2 weeks later and said, listen, I'm feeling so good off the medications. I've looked at all the medications, and I've looked at the literature on how beneficial they are for me with heart disease, and I've decided that I'm happy to do the lifestyle choice and not take these medications anymore. And that's absolutely fine. Now, other doctors may have told him he was about to drop dead, you're not on your statin, you're going to die, all that kind of nonsense. But no, he actually was very well informed. And that brings us on to the most important slide that I've been showcasing around the world, which is something we need to kind of get back to thinking about, is actually what is evidence-based medicine, and are we practicing it? And if we're not practicing it, why are we if we're not practicing it, it would probably explain why we have a healthcare crisis that we've got. So this was put together by Professor David Sackett, considered one of the fathers of the evidence-based medicine movement, published in the BMJ in 1996. And what we want to do is improve patient outcomes. That's what we're supposed to be doing. That's what the public would expect of us. And that's what, as doctors, hopefully, we want to do for our patients, is improve their health. But to do that, we use our individual clinical expertise. That's our experience over time. You can't see this here, but it's basically best available clinical evidence. Fine, don't worry, don't. So best available clinical evidence, and then taking into consideration, most importantly, patient values and expectations. But as a concept, I want you to try and understand this. If the best available clinical evidence is biased or corrupted or wrong, then we're not going to improve patient outcomes. And the situation has become so dire that John Ioannidis, who I describe as the Stephen Hawking of medicine, he's a professor of medicine and statistics at Stanford University, his own analysis suggests that less than 10% of published medical literature is both high quality and reliable and relevant to patients, which means more than 90% is not, which is pretty extraordinary. And a lot of this is because a lot of the studies that are published are funded by industry. They control the data, they control the output. And again, if we as doctors are making clinical decisions on biased information, it's not just unethical, but it's going to give bad outcomes to our patients. And that's what we've got. And I spoke in the European Parliament last year, and I said the situation has, I actually said that honest doctors can no longer practice honest medicine. And there are lots of reasons behind that, and it's not the subject of most of my talk today, but I'll give you a little example about how we've gone wrong in our management of cholesterol and prescription of statins. And if we're not taking into consideration patient values and expectations, whatever we do, whether we prescribe, whether it's a particular diet or an exercise regime or a medication, if it's not something the patient really wants, it's not going to work. And that may be non-compliance with medications, it might be not following the diet plan, etc. So I think we need to think about this. So what else did David Sackett also say, which is also very important? He said half of what you learn in medical school will turn out to be either dead wrong or outdated within 5 years of your graduation. The trouble is nobody can tell you which half, so you have to learn on your own. I did not learn anything about this concept of evidence-based medicine, nor did I learn about this 5% of 50% of what you learn in medical school will be outdated within 5 years of graduation at medical school. And I think that's also a major problem. A lot of doctors don't even understand it. And this is not being critical of the profession. I've been one of these people that had to change the way I think about how I practice medicine. But again, 70% of healthcare practitioners fail the basic test on their understanding of evidence-based medicine. So when I give these talks around the world and people say, well, but my doctor says this, and I said, yeah, okay, you need to educate your doctor. Your doctor needs to keep learning. I always learn from my patients. Every single patient I see that as an opportunity for learning. Your doctor should do as well. Okay? So this is, medicine is not an exact science. It's an art, and it's more the practice of the art of probabilities. So the profession needs to keep up to date, but this again is not rocket science. Let's talk about cholesterol. So where did high cholesterol imprint itself on the minds of the majority of the world as being a major risk factor and something to be feared when it comes to heart disease? And it came from the Framingham study. So the Framingham study started in the 50s. It was a study funded by the National Institutes of Health in America, and it followed up about 5,000 people in the town of Framingham in the US. And from that, over 1,000 publications came out of that, and we identified certain risk factors for various conditions. In particular, the concentration was on heart disease. And what this slide shows you here on the left is the ideal risk factor should be able to distinguish between people who are healthy and people who are more likely to develop disease. Now, when you look at cholesterol, in the Framingham study, what was very interesting is that the association of heart disease was only really there at a very strong level when total cholesterol was very high. So these two lines represent people who did not develop heart disease, which is the unbroken line, and the one that's the broken line develops people who did. And so basically, unless your cholesterol is very high, above 10 millimoles per litre, essentially, or very low, for everybody else, your total cholesterol was not able to distinguish who was going to develop heart disease and who wasn't. And the very low level was less than 3.8. And what many people forget is most of your cholesterol is genetic. About 80% of your cholesterol is genetically determined. You can influence it by diet. You can influence HDL and triglycerides, which I'll come on to a little bit. But your total cholesterol, most of it is genetic. And so basically what this was telling us was people with genetically high cholesterol, something known as familial hyperlipidemia, which affects anything from 1 in 200 to 1 in 500 people, there was a very strong association. And people who had genetically low cholesterol seemed to not get heart disease. Now at the time it made sense when this came out. It was, well, actually that means there must be, maybe this is linear. we should be driving as many people as possible into that small area where there was genetically low cholesterol, but that actually has not worked for lots of reasons. What else did Framingham throw up? So William Castelli was one of the co-directors of Framingham in 1996. He wrote in Atherosclerosis something else which is very interesting, which I didn't know till a few years ago. He said that from Framingham, unless your LDL, which is your so-called bad cholesterol, was over 7.8 millimoles, it was essentially useless in isolation in helping to determine who was going to develop heart disease. As a risk factor, it was not very helpful. 7.8. Very rarely do I see a patient with an LDL of 7.8. Patients are told that if it's above even 3, 4, it starts getting high, you're at risk, you should get your LDL lower. But as an independent associated risk factor, it wasn't from Framingham unless it was very high. So the overwhelming majority of people, your total cholesterol is not very helpful in determining your risk. But what Framingham did tell us, and what we use in risk calculators, is that the total cholesterol, which I mentioned before with Tony Royal, to HDL ratio was the most predictive. It was the most predictive for all age groups and for males and females. And therefore, when you look into risk calculators for heart disease, it's actually the total cholesterol to HDL ratio that's important. Now, why again is that important? You may have 2 patients who come to see the same doctor, and one patient's total cholesterol could be 7, and he's alarmed. And I see this all the time as a cardiologist. I see patients come to my God, my doctor's told me cholesterol 7, etc. But that person's HDL could be 2, right? So what's the ratio? 7 divided by 2, 3.5. And that patient is unduly alarmed because actually their risk is actually quite low based on their cholesterol profile. Another patient comes in with a cholesterol of 4, with false reassurance. Their HDL is 0.8. Okay? So basically, their ratio is 5, and they're at much higher risk than the patient who had a cholesterol of 7. Does that make sense? And that person gets false reassurance. They may well have the metabolic syndrome, which David talked about earlier. So this is again a problem. This whole focus about high cholesterol and lowering it is really more marketing than science. It's more marketing than science. So let's just acknowledge that for a second. Okay, now when we talk about heart disease, there are risk factors, and there are a hierarchy of risk factors. So what is that hierarchy? What's the most important risk factor for heart disease, or most important determinant? So in 2011, a study was done, a mathematical modelling study, looking at all these various risk factors to try and predict what would be the best approach to manage heart disease. And what they found was that insulin resistance was actually the number 1 risk factor. And they did a calculation in the study that they say if we target people aged between the ages of 20 and 30 and target insulin resistance, and reduce it significantly, then we would prevent 42% of all heart attacks. After insulin resistance, high systolic blood pressure. After that became low HDL cholesterol, the so-called good cholesterol at a low level. Then it was body mass index. And LDL comes much lower down, 16%. Now, I suspect a lot of those patients with the LDL who they were targeting probably had familial hyperlipidemia, or would have LDL, which is related to a high sugar diet, again, which is another topic. But the point here is insulin resistance was the most important risk factor for heart disease. And what they concluded is they said that insulin resistance is likely the most important single cause of coronary artery disease. A better understanding of its pathogenesis, its cause, and how it might be prevented or cured could have a profound effect on coronary artery disease. They're essentially saying we don't know what to do about it. We don't know what to do about insulin resistance. We've identified it as being and this is consistent. So I'm not just taking one study. Most patients admitted now with heart disease, with heart attacks, okay, most of them, 2/3, have what we call as the metabolic syndrome, which is synonymous with insulin resistance. What is metabolic syndrome? It's any 3 of the 5 of increased waist circumference, high blood triglycerides, low HDL cholesterol, pre-diabetes or type 2 diabetes, and high blood pressure. So body mass index is not in there, neither is LDL. Because most patients also have a normal cholesterol who admit it. So the elephant in the room is that we should be focusing on insulin resistance and metabolic syndrome if we're going to manage heart disease. Let's muddy the waters a bit further about cholesterol and LDL. 2016, I was involved in some original research, a systematic review looking at all the evidence on what the association of LDL was in patients over the age of 60. Now what Framingham also showed, which again was not well publicized at the time, is that after 50, total cholesterol even seemed to be less of a risk factor after 50 and tended to drop. And actually what they found was in the Framingham study, as cholesterol dropped after the age of 50, there was an increase in death rates. And after 60, there seemed to be very little association with total cholesterol and heart disease. So what we did is we looked at how does LDL, so-called bad cholesterol, link to heart disease in patients who are elderly, over 60. Well, over 60 actually is still quite young now. I mean, probably elderly is very over 80, but over 60, so still relatively young. And we were quite surprised with what we found, actually. I thought there would be maybe a weak association, but there was no association. So if you're over 60, there was no association with LDL cholesterol and heart disease, and there was an inverse association with mortality. In other words, the higher your LDL, the less likely you are to die. And I remember shortly after this, we published this, and it was press released, and I was speaking about it on Sky News, and it was mentioned in the newspapers. I wrote about this in the Telegraph newspaper, this story. But a patient came to see me in her early 60s. So she came to my cardiology clinic at National Health Service, and she walked in the room, and she looked very anxious. A lot of cardiac patients are, or people who are worried that they're going to have heart disease, look anxious when they come in. But she looked very anxious. I said, "What's wrong?" She says, "Oh, I'm really worried. My doctor, my GP, has told me my cholesterol is high." And she was 62, 63, and I said, "Congratulations, you're going to live longer." And then I explained her what the up-to-date evidence showed, and she was very reassured, and she left reassured. But again, she was put under this unnecessary fear that she didn't need to have. I started this campaign, this sort of activism, because I saw over my career increasing stress on the system from people coming in with more and more chronic disease, more obesity. And I wanted to try and investigate how we'd got to how this situation had arisen. And one of the things when I looked through lots of research and started analysing lots of papers and data and looking at the reliability of it, I realised that we had this misguided focus on saturated fat, on lowering saturated fat, because the evidence had suggested there wasn't really a very strong association with saturated fat and heart disease. It was there was very conflicting evidence. And at the same time, I was personally acknowledging and looking again at the evidence around how sugar affected metabolic health, but also how the food environment was saturated with ultra-processed foods that were being marketed as low-fat and were loaded with sugar. And I could see that around me. I was observing it. I was seeing it amongst the patients. I was seeing it amongst the staff in my hospital. David mentioned about the fact that a lot of doctors don't understand, the very basics of nutrition. We're not taught about it. But actually, the problem affects the medical profession as well. In the NHS, we have 1.4 million employees in the NHS. 50% of the NHS employees, including doctors and nurses and non-clinical staff, are also overweight or obese. So this is something that's affecting us all. So I looked into all of this research, and then I published an editorial which was peer-reviewed in the BMJ, which became very controversial at the time for lots of different reasons, saying that saturated fat was not the major issue. It was press released. I didn't expect this to happen. I wasn't a consultant cardiologist at the time. I was an interventional cardiology fellow. And then it was picked up by 3 British newspapers as a front page news. I think the new thing was really a cardiologist saying butter is back. And I went on BBC News. I was on CNN International. It became, it was a pretty hectic time, but it was good. I was able to justify what I was saying, and really summarising where we'd gone wrong with saturated fat advice. So the reason why we had demonised saturated fat for several decades was based upon the work of an American scientist called Ansel Keys, and he did something called the 7 country study, where he made a correlation in these countries between the consumption of saturated fat, cholesterol and heart disease. It wasn't a very robust, high quality study. There was a correlation there, but actually we found, and in fact it had such a big impact and influence that it changed dietary guidelines. So in the 1970s and early 80s in the US and the UK, we then changed our dietary advice and said we must reduce our consumption of fat and less saturated fat to less than 10% of calories. And what happened as a result is the food industry came in and they took this low-fat mantra and they, started marketing a lot of low-fat junk foods, ultra-processed foods, and we, in the population, in many of the Western populations around the world, then increased our consumption of sugar and refined carbohydrate foods, and that has directly correlated, and I believe it's causal. You can never truly prove this, but there's been a very strong correlation with a change in dietary advice to the increased epidemic of type 2 diabetes and obesity. So this is some of what I've written in my piece in the BMJ. what was interesting again is that Keyes had missed out other countries. Now I don't know why he did this, only he knows why he did this, but there were other countries that when you included them beyond 7 countries into 16 other countries, the correlation between saturated fat and heart disease seemed to diminish. It was still there, but it was much weaker, and again an observational study, so you can't show cause and effect. Keyes was also, and I don't know if this biased his view, he was also funded by the sugar industry. He did take money from the sugar industry. And around the same time, when Ansel Keys was saying that saturated fat was the major driver of heart disease, a British nutritionist called John Yudkin said it was the sugar. But unfortunately, Yudkin was not as powerful or as influential as Keyes was, and his voice was sort of drowned out until around 2011, 2012. Robert Lustig, who's a pediatrician in America, he started publishing some new data and research suggesting sugar was the main problem, and then we've moved forward from there. So why does saturated fat on a biological level not cause heart disease? Well, if you remember the total cholesterol to HDL ratio, what saturated fat does, and again had been forgotten and missed, but when I was looking at all the research about how saturated fat affects cholesterol profile, it raises HDL. It raises the good cholesterol, even if it has an effect on LDL, which actually is often quite weak. And certain saturated fats, there are many different types, don't even raise LDL at all. They raise HDL. So the effect on the cholesterol profile ultimately is neutral. So I'm not saying saturated fat is good for you. I'm not saying saturated fat is protective against heart disease. You can eat very nutritious foods that are high in saturated fat, but when it comes to heart disease, the effect at worst is neutral. And of course, again, something else that was missed is the different types of saturated fats. So you get different saturated fat that you find in palm oil, which is different to red meat, which is different to dairy, which is different to coconut oil, which is different to olive oil. Even olive oil, that most people consider as a health food, some of the best quality olive oils have anything from 14 to 20% saturated fat in them. So they all have different biological effects. And then in 2016, there was a reanalysis of an Australian study, a very important study called the Sydney Heart Study, which is a randomized trial, and this was published in the 60s, if I believe correctly. And they reanalyzed the data, and they found that cardiac patients who replaced butter with a safflower oil containing margarine, which is high in omega-6 fatty acids, despite lowering their cholesterol by 13%, had increased all-cause mortality. So think about this. So you're lowering cholesterol by eating this sort of food that's proven to lower cholesterol, which you think is going to be beneficial, and it increases death rates. It was just, I'm putting this out there just to get that concept, to understand that lowering cholesterol, it's not just that it may not be beneficial, it may well be harmful. And my colleague in America, who's the editor of JAMA Internal Medicine, Rita Redberg, she says cholesterol is just a lab number. Who cares about lowering cholesterol unless it actually translates into a benefit for patients? So after I'd published this editorial, and it was the first time really this has got back into the mainstream, in the news. I mean, it was picked up everywhere. Often what happens is other researchers start looking at data again and suddenly feel that there's an opportunity to publish stuff that may have been ignored for so long. So what happened then I didn't predict. I mean, I could have been wrong, I could have read I could have ignored other research, etc. I felt I'd looked at all of the data that was available, and I thought I was making a very strong point about saturated fat. And a few months later, Cambridge Medical Research Council with the British Heart Foundation then did the largest study combining both observational studies and randomized controlled trials, and it involved over 600,000 participants, and what they concluded is that there is no current evidence to support guidelines that restrict the consumption of saturated fats and replace them with polyunsaturated fats in order to prevent heart disease. They said one interesting finding was that a particular type of fatty acid, a dairy fatty acid called margaric acid, saturated fat, significantly was associated with significantly reducing the risk of heart disease. Now this doesn't prove again cause and effect, but the suggestion was possibly dairy foods are protective against heart disease. So the take-home message is that we need to stop focusing on these individual macronutrients because the food industry exploits it. And I even think the same thing may be happening now with the sugar-free revolution. We get with people reducing their sugar, you're getting all these foods that are being replaced with artificial sweeteners or ultra-processed foods with other rubbish in them which have low sugar. And ultimately, what we should really be doing is focusing on whole foods within healthy dietary patterns. That's what we should be doing. Now, at the same time as my BMJ piece was published, There was a paper published in the BMJ as well by John Abramson from Harvard and colleagues, and they specifically looked at the question about statins in low-risk people with low risk of heart disease. And what they found, and this wasn't new data, it was looking at already published research, which was industry-sponsored research. They found that if you have a less than 20% risk of heart disease in the next 10 years, then there is no mortality benefit from taking a statin. In other words, you're not going to live longer at all. Okay? There are many people around the world who are being prescribed statins, and even financially incentivized doctors, sadly, to give people statins who have a risk between 10 and 20%. I suspect almost all of them, if not most of them, are not being told this is not going to prolong your life by one day, even though the evidence is very clear on that. The independent evidence tells you it's not going to prolong your life by one day. What he did find was, over 5 years, there was a 1 in 140 chance that taking a statin would prevent a minor heart attack and a non-disabling stroke. There was no protection against serious illness. So this was published in the BMJ, it was again peer-reviewed, etc. And what John Abramson said is a couple of interesting things. He said that really in this group of people, rather than prescribe more statins and lower the threshold for prescribing for doctors, we should be focusing on healthy lifestyles. Heart disease, 80% of it is related to the environment and unhealthy lifestyle, so sedentary lifestyle, poor diet, smoking, stress, etc. This is what the focus should be. It seemed very sensible. Now the real controversy occurred at this point because what John Abramson did and what I did in my editorial, because when I was writing my editorial I had to also make sense of the fact if I was saying saturated fat doesn't cause heart disease, even if it does raise total cholesterol, then I'm also going to say total cholesterol is not a major risk factor. And if I'm saying total cholesterol is not a major risk factor for heart disease, how can we explain statins working? And I concluded that based upon other studies with drugs at lower cholesterol that had no effect, that I felt statins' effect on heart wasn't fraudulent data. I thought that the effect was independent of cholesterol lowering, and there was data to show that statins are anti-inflammatory. So that's how I justified it. But what I also said is the side effects have been grossly underplayed. In my career, I've probably seen well over 10,000 patients, and I've managed thousands of patients who are on statins with heart disease. And what I was seeing in my practice, remember the evidence-based medicine tried individual clinical expertise, is that there was a huge discrepancy between the patients who were suffering side effects, which I was estimating was probably anything from 1 in 5, maybe a bit more, to what was published in the literature, the gospel truth literature in the Lancet, the Bible of medicine, which clearly is not, which I'll justify in a second, was saying it was the muscle symptoms much less than 1%, etc., etc. So there was a big problem there. So we said, listen, this is a problem. The side effects, unacceptable side effects, affect 1 in 5, and John Abramson cited them as being muscle symptoms, liver inflammation, cataracts, decreased energy, sexual dysfunction, exertional fatigue, all the symptoms that Tony Royal got, the case study. And also we now know that statins do cause diabetes. They cause type 2 diabetes, and about 1 in 100, maybe 1 in 50 people will develop type 2 diabetes from taking statins. So when you balance that out against a non-fatal heart attack prevention of 1 in 140 with no mortality benefit, then of course many patients, probably most, would decide not to take the pill. And that's what we call transparent communication of risk, which again is not happening in clinical practice. Most patients and doctors are essentially giving information based upon pharmaceutical industry marketing, something called relative risk, and that is unethical. And I don't disbelieve that. In fact, the director of health literacy, the world-leading research on health literacy, Gerd Gigerenzer, in a World Health Organization bulletin in 2009 said it's an ethical imperative that every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. So basically telling that patient, yes, should you take a statin, this is your choice, this is the absolute benefit, 1 in 140, etc. And if they want to take it, fine. If they don't want to take it, that's fine. But that's not what's happening. Medical guidelines are designed at the moment in many places to financially incentivize doctors to prescribe statins, and even without that discussion happening. So we are, and I've been very open about this, I've said this in the public, I've said this in the British media, we are unwittingly practicing unethical medicine unless we have that conversation with our patient in that way. It's called transparent communication of risk. When the papers were published, Professor Sir Rory Collins from Oxford, who's considered the lead statin researcher in the world, whose department in Oxford University has taken hundreds of millions from the drug companies to run trials on statins, he was not happy about what me and Abramson had said about the 1 in 5 patients getting side effects. So he wrote a letter to the editor of the BMJ, Fiona Godley, and he demanded immediate retraction of both these articles, which had been widely publicised. She said no, said we don't do things this way, but we're very happy to publish a critique in our journal, which most academics would jump at, the opportunity to criticise what the errors were and you can make your case. He said no, he said retract. This went back and forth, didn't get very far. And then what happened in the end, either the health editor of The Guardian went to him or he went to the health editor of The Guardian, I don't know. And in March 2014, a few months after the articles were published, I get a phone call from the BBC and from The Guardian asking me to respond to the fact that this very eminent professor and expert on statins is saying that what we had said about statin side effects was wrong, and that as a result, he was very concerned that this may result in many people dying from patients stopping their statin. And he was specifically worried about the high-risk groups, and he may have had a point, okay? He may have had a point. And this is what he said in the Guardian newspaper, which I think is very important for you to remember for my talk, is there are only, he said, Professor Collins said, there are only 1 or 2 well-documented problematic side effects from statins. Myopathy and muscle weakness occurred in 1 in 10,000 people. He said 1 in 10,000 people, and there was a small increased risk in diabetes. So there's a bit of a discrepancy here. We're saying 1 in 5, he's saying 1 in 10,000. Okay? So what's going on? The articles got referred for an independent review. The editor was put under pressure, and I think rightly she felt there was a bias that she had because she published the articles in her journal. So she sent them for independent review about whether it should be retracted. So myself and John Abramson were on trial for a couple of months, which could be career destroying, of course, if they were found to be retracted. I wasn't that bothered so much about that, but more the fact that there was I felt something a bit wrong going on here. This is a complete distraction from the major issue. Professor Collins did not object to what we'd said about the lack of mortality benefit. He just sticked on the side effects issue, so clearly that wasn't incorrect. And we basically got exonerated. So 2 months later, a panel came back, 16 in our favour, said these are very legitimate discussion. We made a slight correction or caveat on the reference we'd used about the 1 in 5. The 1 in 5 side effects had come from a community study and wasn't what we call a randomised trial. So that's really where the caveat came in. But actually, you can't tell. A lot of these trials are not conducted to look at side effects, and you only find out in the real world with patients often how true the side effects are. But we move on. I then started writing more and more articles. I was invited to write stuff. I was publishing more and more things on statins. I was not deterred by this. I wanted to push the transparent communication of risk, what's the absolute benefit, etc. In fact, on that note, before I move on to this, for people who've had heart attacks, such as Tony Royal, the absolute benefit for those patients based upon industry-sponsored data, based upon non-transparent industry-sponsored data, so this best case scenario, is 1 in 83 benefit for death rate reduction. So for Tony Royal, if he took a statin, someone with a heart attack took a statin religiously every day for 5 years, there's a 1 in 83 chance it will save their life, and a 1 in 39 chance it will prevent a recurrent heart attack. Now in medicine, many doctors would think those are pretty good figures. We treat the many to benefit a few. But for the individual patient, Tony Royal looked at that in his own circumstances, and he made an informed decision that 1 in 83 figure, 1 in 39, wasn't good enough for him. I mean, that also means 82 out of 83 are not going to benefit in terms of life extension, and 38 out of 39 are not going to have a heart attack prevented. But again, most patients are not told that, and I think we should be telling those patients this. So I started publishing more and more reviews in high impact journals, and kept this campaign going about greater transparency in prescription of statins. And Professor Collins then comes out in early 2016 and says, okay, and he goes to the press, we're now going to reanalyze our own data again, the studies that we've already published, and look at it again to try and see what the side effect rate is and what the benefit is. To be honest, I felt at the time this was foxes guarding the hen coop, because Oxford Clinical Trial Service Unit, they have commercial agreements with drug companies that run these trials, and they control the data, and no one has been allowed to see that data independently to reanalyze it. So I was expecting him to come out with exactly what they've said before. So in September 2016, The Lancet, and a very big news story, you may have remembered it because I know the statin saga was big over here with Catalyst programs and Marion Damasi and all that kind of stuff. They then published another review with many co-authors, and essentially they concluded the benefits of statins outweigh the harms, and maybe 1 in 50 or 1 in 100 might get some minor muscle symptoms, but it's reversible. and that was hopefully to end the debate, and that was it, end of story, okay? So this became a big news story across again. It was also trying to tell journalists we don't want this group, because journalists were reporting on these things. I was writing stuff and talking about the side effects and about the absolute benefits and saying lifestyle is better, and this, you know, this was going on for a while, and they wanted to stop that debate. We should prescribe statins, they're very safe and effective, and that's the end of the story. Now what happened next I couldn't predict. I was in America at the time, and I received a phone call from the chief journalist of the Sunday Times newspaper, who I know, called John Thomas, and he said, Aseem, I've got something really interesting to tell you. And I said, what's this? This then became a story on the Sunday. So these are the sort of excerpts from that particular piece in the Sunday Times investigation. This is what he wrote. He said, Sir Rory Collins, a professor of medicine and epidemiology at Oxford University, led a review into statins published in The Lancet earlier this month, which found that not more than 1 in 50 people will suffer side effects. Okay, talking about these minor symptoms. Collins, who believes millions more Britons could benefit from taking statins, is also co-inventor of a test that indicates susceptibility to muscle pain from them. The test, branded as Statin Smart, is sold online for $99 to the public on a website that claims 29% of statin users will suffer significant muscle pain, weakness or cramps. The marketing material also claims that 58% of patients on statins stop taking them within a year, mostly because of muscle pain. Now, Professor Collins said this was misleading when he was called about this. Royalties from licensing of this particular test can be used to fund university research, but Collins and his co-inventors had waived personal fees. Boston Heart Diagnostics, who were selling this, the device company, said it stood by its claims about statin side effects and that they were based upon published research. It also cited a US task force on statin safety that said randomized control trials such as those used in the Lancet study led by Collins had major limitations because patients with side effects of statins were often excluded. So this is something I learned again in the last few years that we are not taught about in medical school. In many of these statin trials, they had what we call a pre-randomization run-in period. Before the trial starts, patients who are non-compliant are taken out of the trial before it starts. One of the biggest trials on statins was a heart protection study, and it was found that, and it's in there, it's published, but they don't talk about side effects, they just talk about non-compliance. It's slightly vague. 36% of the patients enrolled were removed before the trial started. So this may explain why the discrepancy is there, but as doctors, we're clearly making, and if you're not aware of a diagnosis, I remember being taught this at medical school, if you're not aware of a cause of something, or a significant potential cause of something, you'll miss the diagnosis. If you don't know that it exists, you're never going to diagnose it. And how many patients who have got stomach problems from statins have been sent for endoscopies or looking for stomach ulcers, and the whole time it was a statin causing it, and they do cause lots of potential different effects. Now, having said that, yes, most of these are reversible. When you stop the drug or you lower the dose, they are reversible. And you can usually tell within a few weeks of stopping the drug. Moving on quickly, so John Thomas then did a Freedom of Information request about how much money Oxford had received, and they'd received more than £300,000. His department over £100,000 over the 4 years that this was being marketed in this way. I also found out Professor Collins filed this patent in 2009. 4 years before we published our articles. So I'm still very puzzled by this. I've not really got any answers from anybody on this. Certainly not from Professor Collins. Why did he invent the test to look for side effects of statins when they were so rare? And why? And how long was this marketing going on? The money going in, they didn't know how the money was coming in, and I'm very puzzled. Maybe you have a better explanation than I do. What does the real world data tell us on statins? This is before any media awareness, before someone says media scaremongering is telling people stopping statins. Before any media awareness of statin side effects, I'm a cardiologist that prescribes statins, never mentions side effects. I said to my patient on the bedside after a heart attack, take this pill religiously, it will save your life. That was my mantra. Okay? Before any of this awareness, the largest statin survey in America shows 75% of patients will stop taking a statin within a year of prescription. And I know they're being prescribed by their doctor, being told this is going to prevent them having a heart attack. So why are these patients, are they just, just being non-compliant with their doctor, they just don't care? I don't think so. Most of them, when asked, said it was because of side effects, and muscle symptoms being the most important one. So, have statins reduced mortality in the population? Okay, it's been again a gospel truth. Certainly with heart disease, we think it's been a significant contributor to the decline in heart attack deaths. I even wrote an editorial in the Postgraduate Medical Journal a few years ago, even after the BMJ piece, and I wrote in this because I accepted as gospel truth, statins have reduced mortality in secondary prevention. Have they? Well, one study that was probably the only study that we've got actually on it, and I'm still open if a better study comes out, published in the BMJ not long ago, actually found that over 12 years, again before the BMJ article, before 2013, between 2000 and 2012 over across several European countries, there was no reduction in different risk groups attributed to statins in reducing cardiovascular death rates. None. How is that possible? How is that possible? Is it because the data's fraudulent? No, I don't think so. I think there's actually a legitimate scientific explanation for this. So there's another way of looking at the statistics on statins. If you take the people in the trials, who again we now know is selected, so best case scenario, not getting side effects, and we look at how much longer they will live over a 5-year period. So imagine the patient comes to see you as a doctor, or you're the patient, and you say to the doctor, "Doctor, how much longer will I live if I take the statin?" This is slightly different to the NNT, one benefiting out of 83. It's like taking an average. Some will benefit more than others, and you take an average, okay? How much longer would you expect to live over a 5-year period, having had a heart attack? How much more would you want to add on to your life expectancy over that 5 years? What would you, any guesses? What would you want? What would you hope for? Anyone want to say? How many more months, years would you want?
Who's taking a statin right now? Okay, so
That was good a minute. But how much longer would you expect to live if you've had a heart attack over 5 years?
no, 10 years.
10 years?
Yeah, 10.
Okay, so this was actually analysed, again peer-reviewed, published in the BMJ. The answer is just over 4 days. Okay, so the median increase in life expectancy over 5 years in the specific randomised trials in secondary prevention showed 4.1 day increase in life expectancy. Now, if you think about the fact that most patients stop their statins, including heart disease patients, more than 50% of them within 2 years will stop their statin, it makes sense why you cannot see the decrease in the population, because many people are stopping, because the actual increase of life expectancy across the group is only a few days. Now, coming to an end, I won't take your time too much longer. We've talked about this issue about cholesterol lowering, LDL lowering, etc. We've accepted it. You know, there is the American Heart Association put out statements saying that for every degree of LDL lowering, you get a reduction in cardiovascular events, etc., etc. But what they're doing is ignoring the totality of evidence. In fact, there's been 44 randomized control trials, many of them drug trials, which significantly reduced LDL. None of them showed a mortality benefit. Most of them did not show any benefits in preventing non-fatal heart attacks, and many showed harm. So there is clearly a problem with this, with the way that the information is being presented on LDL and cholesterol. And the unintended consequences, which is really, I think, what's been part of driving behind the driving force behind obesity and type 2 diabetes, is we've now prescribed statins to millions of people who are at low risk. Statin users will mistakenly believe that they can eat what they want. That does exist. It's called statin gluttony. You then convert many healthy people into type 2 diabetics who are not going to live longer from taking a statin. You've then, of course, got the whole low-fat, high-carbohydrate movement of food consumption, all based upon risk of heart disease or perceived reduction in risk of heart disease. And it's also been distracted from more important preventative strategies, such as targeting insulin resistance. A picture speaks 1,000 words. This is something that does exist. I've seen patients like this. They think their cholesterol's fine, they're on a statin, they can eat what they want. Completely wrong. Absolute nonsense. And then this is just my own Twitter survey, because on the NNT for low risk, it's important to understand there's probably about 100 million people in the world who are prescribed statins at the moment. 100 million people. Most of those people are not high risk. Most of them are people in the lower risk categories who are not going to live longer. How many of those patients, those 70, 80 million people, how many of those are actually told they're not going to live longer? And if they were told it, would they still take the statin? I don't think so. So this is complete medical misinformation. So what should we be focusing on? 2017, I published what was the most viewed of any BMJ journal editorial that year, over 1 million downloads, which doesn't happen very often. I was quite happy that it got a lot of attention because I wanted it to get a lot of attention. And it was published in British Journal of Sports Medicine. I published it, rather than it being Aseem Malhotra causing trouble again, I thought I'd get a couple of other eminent cardiologists involved. So Rita Redberg, editor of JAMA Internal Medicine, Pascal Meyer, editor of BMJ Open Heart, all three of us practicing cardiologists, we see patients. And we wanted to just make it very clear that dietaries, I mean, the evidence had evolved even further. It was clearly not causal in heart disease. And actually what heart disease is, it's a chronic inflammatory condition linked to insulin resistance. And this slide really summarizes what we should be doing. The data, from my perspective, really suggests we should be promoting a low refined carbohydrate, low sugar Mediterranean style diet with lots of oily fish and vegetables and nuts and olive oil. And we should be looking at other things that are extremely important, like stress reduction, regular activity, movement, and smoking cessation, of course, is still a problem, especially in developing countries, because the underlying cause is insulin resistance and systemic inflammation, which interestingly is also responsible for about 50% of high blood pressure. So many of my patients who adopt this dietary plan not only get their type 2 diabetes into remission, but they've come off their blood pressure pills. So it will also reduce blood pressure for many people because insulin resistance is one of those major driving forces of high blood pressure. So this is what we really should be focusing on. I went to a Southern Italy village called Pioppi, which is one of the healthiest villages in the world, with the chap on the left of the picture here, who is Donald O'Neill, former international Northern Irish international athlete, and my co-author on my book, and we wrote this book called The Pioppi Diet, which was really a lifestyle plan. Diet comes from the original Greek word dieta, which means lifestyle, and it was actually to target the public, but more importantly doctors. So I had the chair of the Medical Royal College, is arguably the most important doctor in the UK, who said every medical student, doctor and household should have this book. I got the former Secretary for Health and the Mayor of Manchester to endorse it, Cochrane researchers, dietitians, you name it. And I did this because I wanted this, I knew this was going to get attacked, which it did, and I'm not going to talk through all of that at the moment, but I wanted to make sure that we had, credible establishment, people on board with this, because of course it was going against the dietary guidelines again. The dietary guidelines say place starchy carbohydrates, bread, pasta, rice, potatoes at the base of your diet. We were saying no, these are the biggest driving factors behind metabolic syndrome, and really for this particular plan you should cut them out completely, and actually you'll get healthy within, the effects are very quick. So 21 days we see this effect. And the most important message is that lifestyle changes are more powerful than any drug in preventing and treating heart disease and come without side effects. Stephen Ties is somebody on my Facebook who was very happy to share this. It's just N equals one patient, but just to give you an example, this chap followed this plan within 3 months, come off his type 2 diabetes medication, sent his type 2 diabetes into remission, also came off his blood pressure pills, lost weight, and he's very happy following this particular plan. This is just to show that Andy Burnham on the left was the Secretary for Health under Tony Blair. He is now the Mayor of Manchester. He was fully behind it. He said this has the potential to make millions of people healthier and happier. And that was really to get political involvement as well. But he's been supporting my work for a long time. Sarah Cox is a well-known BBC broadcaster. I don't know her. She contacted me out of the blue through Twitter and said, listen, I wasn't particularly overweight, but I had this, what did she call it? She called it some sort of, I don't know, just a spare tire or whatever around her waist, I think she said. But she lost weight within a few weeks and felt better, healthier. And then around the time the book was released, I got called from a Dutch production company in Holland, and they wanted to experiment just because they thought it would be good for TV, but they're kind of a current affairs program for me to talk around the science, but then put 3 Dutch people onto my diet plan for 28 days and see what happens. One of them had type 2, the other one had high blood pressure and recently diagnosed with heart disease, and the third was a lady who'd struggled with her weight for a long time, gone through bariatric surgery, tried every diet under the sun, and was struggling. So they basically took these 3 people, they put them on my diet plan, they had a GP following them up, looking at everything from their waist circumference to their bloods, their cholesterol profile, blood pressure, etc. And then they took them to Pioppi, this village, which we based the book on, 28 days later, and on camera, while it was being filmed, got told their results. The chap with type 2 diabetes not only came off all his medications, but sent it into remission in 28 days. The chap who had high blood pressure was able to reduce his pills, and the girl who suffered from weight problems, who couldn't get around her head initially, thinking, hold on, I'm eating more fat here, I'm eating more fat, I'm going to lose weight. She just couldn't get her head around it, but she lost 10 kilograms relatively easily within a month. And there were, the book was released in Dutch the day after. By coincidence, this program went on air, which was viewed by millions of people, and it was very well done. It was very nicely put together. And then this is them on the left when they got told the news about their blood results. They were so happy. I mean, they were really emotional, to be honest, when they got told their blood results. And the fact they got better, and I'm quite proud of this one. Somebody sent me this from Schiphol Airport in Amsterdam. The book was at #1 for 5 weeks until the Dutch Nutrition Council weighed in. They weren't very happy. It was getting lots of media attention, and then unfortunately made lots of factually incorrect, distorted statements about the book. But that's the way it is. Okay, almost finished. So remember Tony Royal. I thought his case was really interesting. I think it represented so many interesting things about lifestyle, about transparency of prescription, about informed patient choice and what can be done. So with the former chair of the Medical Royal College's Professor Dame Sue Bailey, I wrote this piece in the Pharmaceutical Journal. And what we said is that really this should now be widespread practice, something called shared decision making. It should be part of training for all healthcare professionals to improve collaboration with their patients and save the NHS billions of pounds. What we find, the data tells us, when you give patients truly informed consent, most of them choose not to undergo an operation or take a pill. So not only is it more ethical, but it will also save money, or certainly redirect money to where it's needed most. In our National Health Service, and David mentioned this earlier, we actually need more money directed towards emergency care and social care. We've got aging population, etc. That's where that money should be redistributed. For rather than spending all this money on pills for chronic disease that don't have much effect, come with side effects and neglect lifestyle. The Daily Express in the UK picked up this, that was press released, and about his particular story. I mean, they went with ditch the pills to beat heart disease. Some cardiologists were not very pleased with that. They like the statins, but this is not about, this is about what can be achieved, and then again about having an honest conversation. That's Tony Royal, who then completed his Ironman a few months later, and has broken all his own records on his triathlon since he's gone low carb, so he's doing very well. The pioneering heart transplant surgeon Christian Barnard, perhaps regretfully towards the end of his life, said, "I've saved the lives of 150 people with heart transplantations. If I'd focused on preventative medicine earlier, I would have saved 150 million. Well, it turns out lifestyle is that medicine." Thank you.
Absolutely brilliant.
All right, guys, I want you all to just have a little bit of a stand up and just stretch the legs. You are at the Functional Movement Training Centre, remember? So just do a few little marches on the spot there, guys. And Christine, can you pop out as well? Christine Cronau. How's everyone feeling? How fantastic was that talk?
Sensationally good.
Yeah, brilliant. Absolutely brilliant. So what we might do now is just grab 3 chairs. Oh, okay. I don't even know what time. It's 8 o'clock. So it's 8 o'clock, and if you need to get out of here, you can. But like I said at the beginning, this is really a really great part of the night, is where you guys can take the microphone or just yell out and just talk to Christine, Aseem. I'll try to be Tony Jones and moderate the question Q&A style, so it doesn't get too crazy. Aseem, all I can say is, how the heck do you do it? You're a practicing clinician. Is Di still here? She's my practice manager. I'm obviously not working hard enough. So, I'm a clinician. I don't know how you do. What's the secret? How do you get time for seeing patients and researching and travelling around the world? What am I doing wrong? Am I doing too much functional movement training?
A lot of this work I was doing while I was working as a full-time cardiologist. In the last couple of years, I've reduced my clinical workload, but I still do about 3 to 5 sessions a week. It just takes a lot of my time, to be honest. A lot of my weekends. I haven't probably had a proper holiday where I've been able to switch off for about 5 years. There's always something going on. But when you take something like this on, you just, it becomes a kind of responsibility to keep pushing it. And the patients inspire me. My patients inspire me.
So,
and it, yeah.
You just get a kick out of it. It's totally selfish because when you make people feel better, you feel better. Right?
No, that's actually a good point. Yeah. It is, in that way, it's selfish.
And that drives your passion. And those stories, Tony Royal. When you see that photo in the newspaper, that must just float your boat. That's awesome. I'm going to let Christine take the microphone. Christine, do you want to do a little intro of yourself and just tell the audience a little bit about your newest release?
Oh, well, who here follows me already? Okay, not many. Well, I'm a nutritionist, so I have a master's degree in public health nutrition, and I'm out there doing the same sort of thing, just trying to re-educate people about the fact that we need to bring fat back into our diet. So, of course, my brand new book is The Easy Keto in 30 Minutes. But yes, it's just basically going back to what we used to do before we got all this wrong.
So, there were a few people in the audience that I saw did put their hand up in response to Luke here, my IT man. Could you take that? Just reduce. We don't need that up there anymore. Thanks, man. Or get Sam to help you.
It's a two-person job.
The few people that were using, I can't believe there's not more people taking statins. But what do you think about your current use of statins? Is no one taking statins?
Yeah.
Yeah.
I'm actually called myself medical roadkill. I accidentally went and saw the doctor, and the doctor's mate died of a heart attack, and because I had a total cholesterol count of 6, I got shunted off for a calcium score, which was really, really high, top 92% percentile. And from there I've had an angiogram and then prescribed statins. And you came along just at the right time, because I've had about 2 weeks on them and stopped. So my question to you is the high calcium score in relation to an aged 66-year-old man, and the other question is on what basis would you prescribe statins to somebody?
So I offer and prescribe statins to patients all the time. A lot of the time patients come to me because they're already on statins, so they've been prescribed statins in the hospital, and I'll say now patients. In the hospital I would prescribe them, but again, making patients aware so they know exactly what the benefits are, that it's a small benefit, and they need to be empowered with that information. So, and I'm also very good at detecting, obviously, when patients do get side effects. Now that I'm more aware of it, I'm able to, try people off statins for a few weeks and see if they get better if they're suffering from something which is related to the statin. The key is not about, I'm not against statins, I'm against lack of transparency in their prescription. Now, some patients, unlike Tony Royal, may feel that they're okay, or they may not know. They may say, well, doc, I'm not sure, I can't understand the statistics, what do you think? And in that situation, I would always probably towards giving patients with established heart disease of a heart attack, saying, okay, well, go on a statin, but I wouldn't give them necessarily the highest dose, because there is definitely a relationship between high dose statins and more side effects. But again, say to them, listen, this is not a panacea, this is just an extra tool we have. We really need to do what we can with your lifestyle that's going to have the best impact on your quality of life, and probably going to have the best impact in reducing your risk of having a further heart attack. So that's how I have that conversation. Whereas a lot of doctors don't do that. It's literally take the statin or you will die, and that's it, and go and see a dietitian or whatever if you're worried about diet. And I think that's we're missing a trick there.
Can I give you a follow-up question?
Sure.
Yeah, thank you. What if you haven't had a heart attack? So you don't have coronary heart disease, and then you still put on a statin?
Yeah, so no one should really be put on a statin. This is again why this is about ethical practice of medicine. No one should be forced or put on a statin. You can calculate. So doctors conventionally will calculate the risk. Risk calculate. You can do it. You can do it yourself even. You can, you know, if you Google Q risk calculator, there are lots of different. It gives you age. If you know your blood pressure, what your weight is, total cholesterol ratio, you can find out what your risk is in the next 10 years. If it's above 20%. Then there is probably, you know, from the published data, there is a small benefit in terms of mortality reduction. But again, I use the same sort of figures and say, well, 1 in 83, 1 in 39, and then have a discussion with those patients. Interestingly, many patients, when they're told this information in such a way, would prefer not to take the pill. And that's completely fine, though. That's the right way of doing things. And we've got, you know, it's a mandate from the World Health Organization to this. This hasn't translated itself into clinical practice, though. There are lots of reasons behind that, but most of it is because there is too much influence from the pharmaceutical industry, and there are too many conflicted scientists who are making decisions about health policy, and that's why it hasn't infiltrated itself, you know, across the whole of medicine yet. But it should do, and it will do, I'm sure, eventually, and it will change things. Yeah, I think one other quick thing to say: if you have true side effects from statins. Because I know there was a big media controversy here in 2013 with Marion Damasi's Catalyst programs, right? And by the way, around that time, I shared that program with many eminent doctors in the UK, and they thought it was brilliant. It got taken down. It was ridiculous what happened to her. And it didn't get taken down because there was any factual inaccuracies. They claimed it was impartial because there was too much from the other side. Yet she was going against 3 decades worth of complete bias, and it was a little bit, but the whole thing was nonsense. But after that, I remember they published some studies suggesting that many people had stopped statins and may have died and all this stuff. It's complete nonsense. All extrapolations. There's no... Conceptually, yes, it's possible someone may die from stopping their statin, but there's actually no evidence of that happening to a single patient that I know of around the world, not one. But one of the reasons that is the case is that the patients in the trials where you see that benefit of 1 in 83 and 1 in 39 are not people who got debilitating side effects. Those people are not represented in the trials. So if you have true, genuine side effects from a statin, your risk of stopping it, even if you've had a heart attack, risk of death is 0. It is 0. I'll be publishing on this soon, because they're not represented in the trials. Right? So if it's imagined, this is something called the nocebo effect, then even then the risk for 2 weeks stopping it is very small, maybe 1 in 10,000.
Any questions? Yeah.
Hi, I was fortunate enough to come to the show on Sunday afternoon and had time to think about what you were saying. So we're talking about statins, we're talking about heart disease, but so if we're fortunate enough to come and see you, doctor, you're going to advise us, go and see a nutritionist. 99% of nutritionists are going to tell us to follow the American heart diet. So effectively they're going to tell us to eat carbohydrates, which is going to lead on to higher levels of insulin, which is a greater risk, according to all the discussions. So there seems to be a disconnect. There's a lot of people out there who are coming onto this. I know a lot of people in the low carb, high fat and keto areas. I've had a very great success with it myself. But there's a disconnect. So what is the answer? How do we get around that? What do we do to get over that step?
Yeah. Sorry, but I think Christine may also be able to answer this. You're right that there is still, following the guidelines suggests, especially nutritionists, dietitians will suggest high starch diet. Things are changing. It takes time. In the UK, we've now got approved for the Royal College of General Practitioners have now had on their website a module approved so they can prescribe low carbohydrate diets for patients. So this has happened in the last few months. I met the Secretary for Health, Matt Hancock, a few weeks ago before I spoke in Parliament. He himself is fully on board. He said he lost 2 stones going low carb. So this sort of information is getting to the very highest levels, and now things are changing. The British Dietetic Association, who have been considered me one of their number one enemy probably for the last 5 years. Before I wrote about the saturated fat piece, I talked about the dietary advice on sugar, and that really started the whole ball ring on sugar tax and all that kind of thing. And in that, I pointed out, I went to the British Dietetic Association's website and found that they specifically wrote, sugar does not cause type 2 diabetes. It only causes tooth decay. And then I found that one of their corporate sponsors was Abbott Nutrition, and Abbott had been marketing a formula milk to 12-month-olds that had 9 teaspoons of sugar in it. I found a separate correspondence, and by the way, I put all of this in the BMJ piece that I wrote about sugar and the BDA, that they had previously, there was a correspondence with an obesity researcher saying they had been delighted to work with the Sugar Bureau. So this is a time when the whole sugar, so the BDA, the reason I'm mentioning this, the BDA then, weren't very happy with me, but I had to obviously expose this is wrong. I mean, they need to be called out, otherwise how are they going to change? And there's been an ongoing battle, often with the BDA. They came out and called my book, The POP Diet, one of the worst celebrity diets to follow in 2017. Fad diet, something like that, despite all the endorsements. And then I hit back and exposed them, etc. They were lying about it. The reason I'm mentioning this is only about a week ago, I haven't said this publicly, one of the most senior dietitians of the BDA has contacted me and wants to set up a meeting to discuss the guidance on type 2 diabetes. So things are changing.
That's great.
I think in the UK, like I have literature in my office, and I have to get it from the UK Diabetes Foundation. And I don't know how...
Diabetes.co.uk.
Yes. Anything from Diabetes Australia is pretty suboptimal. It really doesn't hit the nail on the head with the message that I'm trying to get out. So I keep the UK, and maybe you're the reason behind that. But Christine's a nutritionist, and maybe I'd like to ask Christine, like when you went through your nutrition training, can you remember what the messages were?
So the messages are still very, very outdated. The really good thing that I found was when I did my master's degree, it's more research based. So I had absolutely no problem doing my master's degree in public health. But nutrition, that's a different story. It's still very outdated. And we're behind the UK with all of that stuff.
And likewise, I gave a lecture to the University of Queensland dietetics course a little while ago. These were postgrads, so they were recent graduates, and none of them had any concept of insulin resistance. There were probably about 50 grads in the dietetics. I think that's a 4-year degree. And at the University of Queensland, they're about to get out and set up practice. And I put up a few slides about insulin resistance, which is the underlying fundamental problem that's creating our chronic disease epidemic. And they had very, very sketchy understanding, very sketchy. And one fellow piped up in the back, and he said, we must have sugar for our brain's energy. And I said, hang on, mate, just remember where my background, I'm a brain surgeon. And we can do absolutely fine without eating sugar. Our body can make sugar, our brain can survive on ketones. And the other thing about cholesterol is that about 1/4 of the brain mass, if I chop out a brain, 1/4 of the brain mass is cholesterol. And so I see heaps of patients with peripheral neuropathy, and Aseem, when they get peripheral neuropathy, that doesn't get better. That doesn't get better. And peripheral neuropathy doesn't just cause sensory changes; it causes incoordination and poor and motor dysfunction. And so cholesterol is critical. It's like the coating of your electric wires in your house. It creates that myelin that surrounds the nerve. And so I probably get about 10 people off statins a week in my consults. I always write to the GP. I always say, look, so and so's got peripheral neuropathy. They've got some other symptoms probably associated with their statins. Could you please consider trialling them off it? I don't want to upset the GP. And also, I'm a little bit worried in Australia about the Medicaid legal connotations of it, and doctors who don't have enough support for this, and they can find themselves in hot water through our health practitioners regulatory agency. So those are other factors to think about when your doctor's giving you a prescription for statins or any other type of...
I need to take the microphone. Any questions? I don't understand what insulin resistance is. Can you explain that? This is my exercise. Who's going further? Well, basically what happens is actually, I might go back and talk about the fact that a lot of people think that they could not be insulin resistant if they don't have high blood sugar. And in fact, someone came to me a couple of weeks ago and said, my doctor says I can't be insulin resistant because I have normal blood sugar. But what happens is your insulin tends to come up long before the blood sugar comes up. And it does that to try and keep the blood sugar down. Because if we've got this flood of blood sugar coming in, we've got to try and regulate it. So the insulin comes up, and eventually it can't keep up because the cells become more and more resistant to that insulin. It's too much, it can't take it on. So it's at that point that the blood sugar starts to come up. And so that's, by the time the blood sugar comes up, even if it's very slightly, the research shows that there's already probably a big problem. So that's insulin resistance.
Vicky, does that help, or
Look, it's fine for me, but obviously I'm...
Yeah. Aseem, do you want to add a little bit to that?
Yeah, so essentially it's your body becoming resistant to the hormone insulin, which is involved in many functions, including fat metabolism. I think in terms of, there are tests, although they can be a little bit expensive. Yeah, there are tests that you can do to look for it. I wouldn't necessarily go down those specific tests first, because your other surrogates are very helpful and very useful, which is really the triglycerides, HDL, waist circumference. When I gave a talk in the British Parliament, there's a new phenomenon, I think, which we need to talk more about, Rob, which goes beyond obesity, and it's being over-fat. So there's a lot of literature on the over-fat epidemic, and that basically means excess body fat. So I think the thing to think about is insulin resistance almost certainly always goes with excess body fat, and excess body fat now, in terms of adults, is affecting at least 80 to 90% of all UK and Australian adults, which is quite a lot. And what's interesting is the research is now linking it not just to heart disease, but cancer, Alzheimer's. Obviously, we know it's a precursor to type 2 diabetes, but even osteoarthritis. These are chronic inflammatory conditions. They seem to be linked to excess body fat. So I think the shift eventually is going to come to the fact that we need to focus on reducing excess body fat, which again is the substrate for chronic inflammation and insulin resistance as well.
Just to take it to a simpler level as well, as humans, biochemically, we can only take in a small amount of glucose from carbohydrates. We can only use or store a small amount. So if we take in more than that, then we have to do something with that excess, and that's where we get the problem. And it becomes a problem both for our weight in most cases and also our metabolic health.
Hey, James.
Hi, just a question for Aseem. I'm a GP and I practice some low carbohydrate nutrition, and I'm just wondering what you do or how you deal with quite young people, so in their 30s and 40s, with really high cholesterols. So they wouldn't have yet. I mean, sometimes depending on their age, I might organise a calcium score, and invariably it will be 0. But I still get nervous. Some people's cholesterols are really quite high, and I suppose I'm tending to kind of attract these people who are a bit more complicated than the average person. So just wondering how you deal with them. So I'm talking numbers north of 8, like total cholesterol. Even some, in the teens. So no doubt the familial aspect there.
Maybe 2 of these.
Yeah, that's a really good question. I have similar patients coming to me as well. The first thing is, I I look at other things, because obviously the whole point of us worrying about high cholesterol is it going to be a risk factor for this person in development of heart disease, so I need to focus on all the other things as well. So I look at all the other markers of metabolic syndrome in those patients. The next question then is, should they be on a cholesterol lowering drug? I don't think there are any randomized controlled trials certainly that have been done in familial hyperlipidemia. We presume they're going to get some benefit, and of course there's an ethical issue about not treating them. But as you've already said, what's useful now is we have something called a calcium score, relatively new technology being used. And this basically is the best predictor, better than any risk factor, for telling you about your risk of a heart attack or stroke in the next 10 years, because it tells you whether there's any coronary disease there. And the higher the calcium score, the more likely that you're going to have a heart problem in the next 10 years. So if they are in their 30s and 40s and they've got cholesterol of 10, and remember most of these are genetic, then it's not as useful if they're a bit older. But if they've got a calcium score of 0, you can be reassured at the moment there's not a problem. You can always repeat it in a few years. Or have a discussion with them about statin. Say, listen, I mean, the honest answer is I don't know whether these people are going to benefit. What we know about FH, though, familial hyperlipidemia, which I didn't mention in my talk, which again is not something that's very strongly emphasized, but I think very important, is that 70% of untreated women with familial hyperlipidemia, so very high cholesterol since birth, will not develop premature heart disease, will live a normal lifespan, and about 50% of men. So what we need to do now with those patients is identify who are those people who are at risk and who those people aren't, and therefore we don't need to prescribe statins. Do all people with FH need to be on statins or cholesterol-lowering drugs? No, they don't. But we need to get to a point where we can identify who those patients are.
Jackie, what about, do you request a fasting insulin and a subfraction analysis? That's really useful. I think if your pattern A, pattern B, LDL is all pattern A, there's not really too much to worry about, is there? That sort of reassures me biochemically that would, you know, writing back to the GP and saying, hey, I've just got the subfraction analysis back, and it's all pattern A. Why? And they've got peripheral neuropathy. I think we can really safely stop that statin.
Questions?
Hi, team. Obviously, we're using cholesterol as a bit of a surrogate marker of what's happening with the atherosclerosis. Do you have anything that can actually reverse the plaques? There's David Feldman over in the States has done his own little things looking at intimal thickness on different diets, and again, is, you know, N=1, but it's quite fascinating. I haven't looked personally, but are you aware of anything?
It's suspense for the answer.
Yeah, essentially, is there any data that we can reverse heart disease? So it's plausible, if you look at heart disease being chronic inflammatory with insulin resistance, that if you reduce inflammation, then you could probably reduce the plaque burden. You can at the very least certainly halt progression. I've had patients, myself, certainly Tony Royal looks like he had what we call bystander disease, 57% in one of the LAD artery. And that seems to have, in 5 years off medications, has not progressed. It may have reversed slightly. So it's definitely plausible. There is a cardiologist in India who's an interventional cardiologist who takes patients who refuse bypasses and stents, who actually would be recommended them, but they just don't want to go under the knife. And he puts them through intensive meditation for a year, something called Raj Yoga. And he's published data that he repeats their angiogram after a year. A lot of this involves even reconnecting with their family, because stress is a huge driver of this as well. I think it's something it's going to be more and more research on the impact of stress reduction on many of these diseases. And he repeats their angiogram after a year, and he's reported that in more than 50% of patients there has been at least a 20% regression in the plaques, in the coronary plaques. So I think, and that's an observation, but it's still a very interesting observation. So what we need next really is a proper randomized controlled trial. I think I've got the formula to put into that trial, to actually carry that trial out to see whether we can reverse heart disease with specific lifestyle changes. So I think absolutely yes, it's possible. Have we proven it yet? No. But I think we can and we will.
I had a specialist tell me that he felt ethically bound to put me on statins because I had a cholesterol of about 9 and fatty liver. They said it would reduce the fatty liver and reduce my cholesterol. I wonder, how does one respond to that well-meaning gentleman?
It's difficult, isn't it, when in a consultation, when the doctor's the expert and they're giving you this advice very forcefully as well. It's very difficult to argue with it. But you're already empowered, having listened to this talk as well. And I think doctors, all of us, should be receptive to what our patients think. We don't know everything, and often my patients have greater expertise on certain topics related to their health than I do. So I think at the end of the day, you're the most important person in that consultation room. Nothing can be forced on you. Otherwise, it's assault essentially, isn't it? And it's certainly not informed consent. So I think you just need to have that conversation with that doctor. I'm certainly not aware of statins helping fatty liver disease at all. If anything, they probably exacerbate it. So I'm not sure where he's got that from. But maybe next time you go in with some information and some literature, and just ask him to read it. And But for you, statin may be the right thing. I don't know. There are obviously other things to look at. But if you've got fatty liver, the chances are you've got insulin resistance, an element of insulin resistance. And many patients, there's lots of data on this as well, reverse come out of their fatty liver within weeks of basically cutting out the sugar and the refined carbohydrates. So that would probably be my first approach anyway with you.
I'll leave him alone.
This is for Aseem. So going back to the reversal or slowing of the progress, what are your views? Because I noticed that you didn't actually mention any form of meat or red meat. What's your views on plant-based diets for your patients?
So I'm an advocate of a plant-based diet, distinguishing it from, presumably, are you distinguishing that from vegan, or are you just saying, okay? So yeah, looking at the overall totality of the data when it comes to heart disease, certainly vegetables, high consumption of vegetables spanned all across the Mediterranean region. And the biological effects of vegetables certainly also seem to be anti-inflammatory, they're nutritious, etc. So I think they are an important component, certainly. When it comes to red meat, and I advocate that. Even my specific diet plan says at least 5 to 7 portions of, less fruit but more vegetables a day. And I personally, I try and follow my own advice, I probably get through 7 to 10 portions of vegetables a day and some fruit myself.
And how many meat-free days would you have a week?
Yeah, so in terms of meat, I don't worry about the meat. So what I tell my patients as well is when it comes to meat, I say avoid the processed meat. There isn't any, I wrote about this recently in the newspaper, there is no strong association with heart disease with unprocessed meat at all. There's nothing there. And it's extremely, certainly red meat, is very nutritious. It's high in protein, zinc, So I think it very much can be, you don't have to have it, but it can be very much part of that healthy diet. But it's not the base. So I will say, listen, get your vegetables, get your oily fish, get your nuts, your olive oil, eggs, all that kind of stuff, and then not to worry about things like dairy and red meat, etc.
So someone with chronic CVD, you wouldn't ask them to cut out red meat? No,
I don't actually. I have all these patients who come to me and I'm like, somebody came to me recently because of all this stuff, absolute nonsense studies coming across from mainstream media. It's absolutely appalling. It's an embarrassment to the medical profession. The medical profession and some of these scientists are embarrassing themselves really badly with some of the stuff they're putting out, which is agenda-driven, about red meat causes cancer and all this kind of stuff. And a patient came to see me recently, a heart patient. He said, I said, how's your diet plan? He said, I've cut out red meat, doc. I was like, why? I said, I want you to go and have enjoy your steak. Why have you cut out red meat? So, no, I don't. Listen, I don't say have it every day. I actually, interestingly, was part of a coalition of experts that caused some news about processed meat recently. Myself, Tom Watson, the deputy of the Labour Party, and we basically talk about the fact that the nitrites in red meat and bacon get converted to something called nitrosamines, and they are carcinogenic. But even then, that translates into, if you have 2 rashers of processed bacon every day, then there's a 1 in 100 chance, at worst, you'll get bowel cancer. That's what the data shows. But still, across the population, you can have unprocessed meat now. So I think there may be an issue certainly with processed meat. I don't think there should be a specific restriction, but in general, I will say to my patients, cardiac patients, maybe 2 to 3 times a week, you can enjoy a good steak, and I have no problem with that, and it probably do some good.
Sorry.
You're right there.
I'd like to just thank you both for your time tonight. I really appreciate giving me time. A bit confused. You're saying low sugar, but now you're saying mixed berries, and you have a lot of fruit portions in your stuff. So, is fruit good? Is the fruit bad?
Well, it depends what your situation is. So, for example, if someone is severely insulin resistant or even a little insulin resistant, I personally recommend staying off the fruit. So I'm a weight loss specialist. I run a 12-week weight loss program, etc. And that's what we advise. So we keep the carbs very low, strict keto. We do this for a period of time until that insulin resistance sort of resolves. So we see the insulin come down and we try and stabilise it. Then we can put those people often back onto more carbohydrates. But generally, there has to be a good period on a ketogenic diet to get that blood sugar and insulin down. But for other people who've done that, I've been on this sort of diet for almost 18 years. So I went strict keto for a while, and now I do eat some fruit. I do eat some carbohydrates, and same with Aseem. Does that make sense?
Yeah, I mean, I think, again, depends where you are. The low sugar fruits, you can actually look stuff up about which are the lower sugar fruits. I tend to advise my patients to try and choose those. So mixed berries and things like that are low sugar. An apple is low sugar. So you can enjoy that. It depends where you're starting from, where you want to get to. But I think for most people, small amounts of fruit is not a problem. When we talk about sugar, we're talking about really the big for the population is restricting added sugar, and it's basically your fructose and your free sugars. So stuff that's got sugar, ultra processed food's got sugar added to it. It includes fruit juice, honey, and syrups. Whole foods, I'm not so worried about, and whole foods often is whole fruit. Now that doesn't mean some people will eat several bananas a day, and that's not going to be good, especially if they're type 2 diabetic. But for most people, if you're having whole foods and even whole fruits, it isn't an issue. But again, it depends where you are and what you want to achieve. The main thing for people with metabolic syndrome really is cutting out the starch. So it's like the bread, the pasta, the rice, the potatoes, and really going really low on that stuff for a long amount of time. If you do that, you'll have a big benefit.
I think, Mark, everyone's heard of the 80-20 rule. Okay, so that means, if you're good 80% of the time, you can be bad 20% of the time. Okay, but there's one caveat to that, and this is what I say to my patients, just to keep, because my consultations are 30 minutes max, right, and otherwise I'm in trouble. 80-20 rule can only apply from a position of health. If you have diabetes, if you have high blood pressure, if you have fatty liver, if you do have visceral fat, okay, so central obesity, which is very distinct from subcutaneous fat, the 80-20 rule won't work. So those fruits and a little slice of bread, or occasionally Wheat Bix or occasionally ice cream, the 80-20 rule won't work. And I think that's what Christine was alluding to. You've got to earn that privilege by applying the 100-100 rule. Okay, so once you've got rid of your disease, once you've got rid of your insulin resistance, guess what? You've just earned the 80-20 rule. So Friday, Saturday, Sunday, okay, I'm going to go out, I'm going to have a side of chips, or I'm going to have a burger, something like that. But you've got to earn the 80-20 rule. And I think that's a big mistake that lots of people make. They go, but he's doing it, and he's doing it, and he's okay, he's not fat. But they're applying the 80-20 rule because they've got the privilege to apply it.
One last question.
Just a comment on that as well. Been involved in diabetes one way or another for a long time, but the early stuff was sugar content. And then it was simple and complex, sugars and carbohydrates. Then we went to glycemic index, and now it's probably more going to be an issue about insulin response. And so the insulin response for taking the sugar with berries, even if it has sugar in it, is completely different to other sugars. And one of the things that's really allowed us to interpret that a lot better is the continuous glucose monitors. And as a type 1 diabetic, I can eat stuff that we're being told is good to eat, and I can see within a very short period of time what's happening to my blood sugars. Your body can't screen or hide what it's doing to you. You see it all the time. So I think we're in a better place of understanding a lot of these things, but there's still a lot more work to be done to understand it completely. So to demonise something is probably not ideal when we don't understand it, but you can certainly see how it changes. So as a type 1 diabetic doing low carb, look, that's not even an 80-20, it's a 2% rule that occasionally you'll have a little bit of fruit because we can get the nutrition other ways. But we're seeing a lot more now than we ever could years ago, doing blood sugar tests every now and again.
Just a quick one for Christine. Just wondering how often and how much do you get people to monitor their ketone levels? Because I personally don't all that often. I feel like if they're achieving their desired health outcomes, there's no need, and I would only ever use it or recommend it if someone's at a bit of a plateau or they might have a therapeutic reason of wanting to be ketogenic. And then I'm also mindful that at various times there's a shortage of ketone strips and meters, and so I'm just wondering what your approach is with that.
Well, I personally do advise people to, look at their ketones, particularly when they start the program, because number one, it's a motivator. Number two, they can see if they're burning fat for energy, and the key is actually starting to burn fat for energy. Yes, there's a shortage of ketone sticks a lot of the time. Some people do have to go to, breath meters or blood meters, but after hunting, a lot of people can find the ketone sticks. But it's really helpful to see if people are starting to burn fat for energy, because if you never drop down into that fat burning state, that's going to be an issue as well. So I know a lot of people who've been low carb, high fat, even long term, and have still not burning fat for energy, and they have to drop their carbs a lot lower.
You smell it on
Does that make sense? Pardon?
You smell it on your breath when you hit ketosis.
Oh, it's for some people, not everyone, and in fact a lot of people talk about the keto breath, but as I often say, it's normally quite temporary. It's normally when they're just transitioning. But the other thing to remember as well is that keto breath kind of has a sweet smell to it. It's not meant to be foul. So a lot of people have this impression about keto breath that it's quite bad, but actually a lot of time we have an imbalance of gut bacteria prior to that, and then when you go into ketosis, that can kind of exacerbate that. And often it's just a matter of addressing that imbalance of gut bacteria rather than the keto breath being a problem. Does that make sense? Yeah.
All right, guys, you good? Excellent. I feel fantastic. I think it's been a fantastic night. It's achieved all the objectives that I wanted out of the night. Last little thing, Christine does have a few copies of your book. If you're interested, hit her up. Find out how you can get it. I haven't got my copy yet, Christine.
Oh yeah, I'll give you
thank you all very much for coming. You saw Aseem's handle on Twitter. Do you reply to people on Twitter? Sometimes. Yeah. Facebook. Yeah. Aseem even follows me on Facebook, so that's pretty cool. So thanks all very much for coming, and have a safe.